and also would like to thank Circe for inviting me to give this talk. Unfortunately, I have to spoil you a little bit. There are not so many news about AV malformations in the kidney, but I'm going to show you nice cases and give you a little bit of structure in order to confront this. I have nothing to declare in consideration to this talk. We all know that the congenital AV malformations are very rare incidences, and as I said, they're considered to be congenital, and they may declare in childhood or puberty, and also can progress in pregnancy and also following trauma, where Deborah will show us in the next session, of course, or in the next talk about traumatic injuries of the kidney. What is the clinical presentations of these patients? They come with hematuria, with flank pain, hypertension due to angiotensin-aldosterone pathway, and also some of those patients come to us with high output cardiac failure. What kind of diagnostic we have at hand, and this is one of the learning points that I also wanted to stress out to you. Of course, we have the ultrasound. We all know the drawbacks of that. But in preparation for this talk, I found this nice functional MR study showing before and after embolization of an AV malformation in a transplant kidney, and that really shows nicely what we're actually doing as an IR and how we can treat and increase then the functionality of the kidney. Of course, we have CT angio at our hand. And to nowadays, there's also possibly to do 4D and CT angios, of course, in the drawback of radiation exposure. So what is actually our main therapy goal that we want? We all, of course, we want to obliterate the AV communication. And I find that very interesting if you think about AV malformation, that you actually think of a venous sump that actually draws your blood and therefore is a really complicated, in some cases complicated malformation that you have to treat. The proximal occlusion, if we go to the feeding artery, is actually equals the surgical ligation, and that is doomed to failure. So what we want to do is actually to go as deep as possible. Concerning our transarterial path, you have to keep in mind that, of course, we have a risk of parenchymal infarction. And if we take the transvenous route, there's, of course, the risk of dislodgement of the embolic agent that we're using, for example, to cause a lung emboli. But what is also at our hands is the direct puncture in order to directly puncture the AV malformation, but that encounters with an increased risk of bleeding and injury of the organ. So to get a little bit structure in the AV malformation, just for completeness, and Deborah will talk about traumatic injuries hereafter, but we all have these cases when the kidney gets punctured or there's a trauma through car accident. We have a direct fistulous formation between a single artery and a single draining vein, and also associated with coexisting pseudoaneurysms. Here I brought you a case that I did after a kidney transplantation, where a probe was taken from the left kidney, and you see very well this nice AV malformation and also the communication that we have from the feeding artery to the vein. This we can easily treat with detachable coils in order to really go at the junction of the AV malformation and preserve as much kidney as we can. Another case that everybody from us knows, this is a kidney that has been operated from the colleagues of the urology department, and postoperative you see a pseudoaneurysms. They're located with this large AV malformation. I just wanted to show you also here the angio of the same patient, not that we're here at the end point of our embolization, but also the associated pseudoaneurysms that are there, and that in many areas you have multiple areas where the AV connection can be post-traumatic. The other large group, and these kind of classification actually come from the neuroradiology field. There we have the non-traumatic type 1, Where multiple arterioles, I think we also have to keep in mind that we're talking about less than 3 or 4 of these arterioles are associated with that. Often, like the arrows indicate, pseudoaneurysm, shunting to a single draining vein. And that what comes in mind then with the big sump of the draining vein being at hand. So here we have a nice example of those. A lot of pseudoaneurysms located here. And this is courtesy to Professor Wohlgemuth, who gave me this case for this talk. And here you see this large draining vein. Also here in the angio, in the dynamic, where you can see all these tiny little connections that you see with the large draining vein at hand. This we can treat. There are different kind of options that we can treat. In this case, there was used onyx with a classical pull and push technique. So what is at our hand? We can think of transarterial if the route is, like in this case, easy with a deep or very selective option to actually treat those. But also we have a transvenous or also a combination of both ones. We have, of course, the coils at hand, the plugs, the glue. Here I really like the flow control technique in order to, when you're actually at the artery, you can use a kind of a jailing technique, have another microcatheter at hand, and then blow up a balloon, and then you really have a good control of how you get your liquid embolic agent at that area. And of course onyx or squid that I showed you in that case with a classical plug and push technique. So coming to type 2 of non-traumatic renal AV shunts, we have a single or a few arteries shunting to a dilated draining vein, and there are no associated pseudoaneurysms in that area. So here's a case that I did last year. In the ultrasound, you see this large sump, this large main draining vein being located here at this kidney. Here I also brought the CT in 2018. This was actually also already seen, but we saw a progression. Patient had suffering from pain and also started with onset of hematuria. And here you see the CT scan at 2022. Here, show you the angio, where you see this nice feeding artery with this large sac. So also what is debatable in such cases, also to take the transvenous route in order to embolize this. We could embolize this nicely with coils, also here detachable coils in the beginning, and then filled it up. And seeing no defect in the kidney here, you see this large area where this still the area of the former venous sac spin, which has developed over time. Here the post-embolization ultrasound showing no perfusion deficit of the kidney and thrombosis of the venous sac. Here, what I found also to show you, to give you at hand the venous approach of this nice publication from Lee, showing also these type 2 AV malformation with multiple connections from the arterial side, and also here the main draining vein. Here you see the catheter being in place at this venous leakage. Also here a cartoon of that, and with a very nice post-interventional result with no loss of kidney function and also preserving the arterial perfusion. So for type 2, we can also use the transarterial or transvenous route also to perform a direct stick, which I'm not showing yet here right now, or if you're having trouble, you can also always combine these two procedures. Also at our hands are coils, plugs, and sclerosant, as well as glue and onyx. The last one is the type 3, where you have multiple shunts between the arterioles and venules, forming a complex vascular network. And actually, due to this complex vascular network, we have the only one thing at our hand in order to really prune down to the deep area in that area. So this has to be only treated with liquids, and we want to perform a deep penetration of the embolic material to the area of the shunt. So actually to give you a little bit more at hand how you we should act on that is that embolic occlusion has to be as distal as possible in order to reduce also the perfusion that can possibly can happen through collaterals. And if you're using liquid embolization, I can just recommend you that you should use frequent angios in order to anticipate the flow changes which can happen. The dynamics change a lot, so what you don't want to encounter with your liquid embolic agents to have a misembolization. So what we want actually to do is to reduce the shunting, and this can then therefore have a higher increased risk of non-target embolization. There are only a few studies of comparing intervention. I just brought you the latest one and the one that actually has the most cases here from Huang from 2016. They treated 11 patients. They treated different types from 1 to 3, and most of the time they used the transarterial approach. In that year, I think also the transvenous route has been not so much established. But you see also the sclerosant that's been used, still ethanol also in that place, but also coils and other liquids with a very high degree of devascularization with low degrees of infarction of the renal. So I want to summarize and conclude. The therapy reliable is on the type of AV malformation, so it's of crucial importance that you take a look at your imaging if you have it at hand, and if it's possible, do a dynamic imaging as I showed with MRI or CT. That is important for the planning in order to start with your procedure. You want to occlude at the site of the abnormal communication. That's common sense, but we want to go as distal as possible in order to reduce the risk of building up collaterals. We have different routes at our hand. Transarterial, think about also transvenous if you have complications, and also the direct puncture in combination of those can really help you. Thank you very much.
Thank you very much for this excellent talk. Are there direct questions from the audience? Then I would start with a question. Of course, we will all agree AV fistula coils is the tool to go. But in some cases, we have to use glue. And we can all be trained, we can use that. If you look in the literature, it's ethanol, ethanol, ethanol. I have never used ethanol, and my teachers 20 years ago never teach me that. Is ethanol still a thing in AV fistula?
Yeah, difficult answer that I can give you. I also never used ethanol, so I cannot give you that at hand. Never trained that, but that's the only thing that you find in the literature, because unfortunately AV malformation are so rare that we don't have much data on that, giving us the difficulty in order to give a direct answer to that, Boris.
We have one question from the computer system. The traumatic case is an AV fistula and not a real AV malformation. Do you agree? Because these fistula are easier to treat than real AVM with different approach from both sides.
Yeah, I think that's right, but I don't want to already talk about so many about injuries, because Deborah will give her talk just right after. But that's true. I just put that traumatic cases in form of completeness in order to show and give you a hand to that you have a nice structure in order to differentiate between traumatic, non-traumatic, and the non-traumatic are the ones where we have the 1 to 3 types.
We have a very interesting question, the second one. What do you do when a pregnant has hematuria due to a kidney AVM? Do you treat it soon or wait until after child delivery? A situation I never had.
In pregnancy?
Yeah.
Okay. Sure. It depends on how much the hematuria is, and you always have to think of the risk stratification. I think if the woman is at risk, and also due to the hematuria is so severe that she and then unfortunately the child would also suffer, I would go into that place. I just had a case, but this had nothing to do with the kidney. A large aneurysm being located from the uterine artery, also in a pregnant woman. Due to the increase in size, it increased over 2 to 3 weeks for 2 and 3 centimeters. So we were in the need of treating that, and also had then to treat a pregnant woman. Yeah.